go through a timeline over the last 10 years, and I really just plugged in, just from memory, what I thought were significant events over our course of the last 10 years. I'll talk about where we are today, where we've been, where we are, where we should go, really under three significant themes, which are the power of networks, our ability to do surveillance of harm, and talk about culture. And then in the context of that, really talk about how all of that has really led to significant changes at M Health as well as across the health system. And it will run through there. This is a picture I just added about 10 minutes ago. This is all my in-laws. So in the middle there is my mother-in-law, Mary Jo Anderson. She passed away about 7 hours ago in her home in Toledo, Ohio, surrounded by all of her kids. She died of cholangiocarcinoma. She was diagnosed. This was taken shortly after her diagnosis in August at a family wedding. And I put that in there just more as an anchoring slide for me, but also it's a reminder that, none of us comes to work to change the world necessarily. We're all doing little bits of change that does that eventually leads to significant waves and perhaps tidal waves of change. She did this with her 8 children. What's not pictured here are her 40 grandchildren, who are all amazing, wonderful people that have her impression through her modeling. And so as we think about this work, and after we leave this room and the work we do, we go take care of patients, or we're thinking about better ways to teach this, right? How to deliver better care. We think about how to cure disease in our labs with the research we do. And certainly something we do today is not going to create a sea change in the world, but it will create a ripple, which may lead to that. So so this talk is in honor of her, and I know she's looking at this. Her father, interesting, was a general surgeon in Toledo, Ohio, pretty prominent, was president of the AMA for a number of years back when the AMA was a huge, pretty powerful organization, still is, but so she none of her kids are in healthcare except for me. She has a daughter who's an oncology nurse, pediatric oncology nurse at Children's, but she and I are essentially the healthcare interpreters for the family. And but she would always take an active interest in what I was doing and what I was interested in. And so, Mary Jo, thank you. All right, so quick review of our timeline. So this is what I call the ripple timeline. So back, in 2005 to 2011, care delivery looked very different than what I think our residents and fellows think of care delivery today. One, we were on the other side of the river. We were running around grabbing green charts and flipping dials to let people know that orders were ready. We were actually writing orders in the chart. So for you residents, it was like epic downtime, 24/7, 365, right? That was how we delivered care. We would sit in conference rooms with all our green charts stacked up and talk about patients, among ourselves, and then we'd go to the room. We weren't doing any of this stuff. And so this period from 2005 to 2011, in the red, what you'll see are things that we implemented on our units that really led to significant changes across M Health, across the medical center. So the ICU did a ton of work around CLABSI reduction. We'll look at that data later, but I think we forget how often we would have central line associated bloodstream infections. It was just very, very common. We just hardly ever see them anymore, thanks to a lot of work. We introduced rapid response teams on the floors. So we used to fairly often have true code blues on the floors outside the units. Again, this is a rare occurrence in care delivery today. We implemented bedside rounding, family-centered rounds, which now has become kind of the standard across our units. Again, the electronic medical record, people remember Eclipsys, Allscripts. Those were EMRs we used to use. We switched over to Epic. And really that changeover forced us to think about how we standardized care delivery, right? We had to develop order sets. Okay, what do you want in an admission order set? What do you want for a CF exacerbation? What do you want for a NICU admission, a PICU admission, et cetera? And so in many ways, it forced some standardization around how we delivered care. The old 5A where we used to, so the Children's Hospital used to be on the 5th floor of the adult medical center. 5A, B, C, and D were basically med-surg, the PICU, and BMT. And the older faculty, or not older faculty, but faculty who've been here long enough, remember that. And we used to, the old 5A was the first unit that we rose our hands and we'll do electronic order entry. We were the first unit to do electronic order entry in the medical center. We were also the first unit to do electronic progress notes. So we were just kind of young and naive and had no idea, but this led to, again, significant sea change about how we thought about care delivery. So the fact that I could literally pick up my phone and click on any patient in the hospital, on Epic and see exactly what their vitals are was just so foreign back then. I mean, to go look at someone's weight or vitals, you had to go grab a chart and look at the flow sheet. Now it's all electronic, and I think we kind of take that for granted. We happen to move into a new children's hospital. Also in this period, we've had about 4 name changes, right? I mean, so lots of other change. As we move into kind of the last 5 or 6 years, we developed the harm index, which I'll go into. We introduced the daily safety call, which I'll talk about, which again, wide and then across the entire health system now. We joined the Children's Hospital Solutions for Patient Safety, which I'll talk more about back in 2013. In 2014, we really started to understand how we organized ourselves around hospital-acquired conditions. And we developed these work groups around surgical site infections, more continued focus with central line-associated bloodstream infections, CLABSIs, catheter-associated urinary tract infections, pressure injuries, adverse drug events. And then in 15, we developed a serious safety event committee, which again, now the entire mHealth is beginning to organize themselves around this nomenclature, around how we understand serious safety events or preventable harm. We won the Minnesota Hospital Association Large Hospital Patient Safety Improvement Award in 2015 as a result of this work. We introduced med student QI interns the summer of 2015. That has grown, and now we're going to have, 6 or 8 first year going into second year med students this summer doing QI work. It's been a really valuable experience for them and for us. We started air prevention across all our staff and faculty in 2015. We'll talk about that. We got, and the hardest thing was actually getting budgetary approval to do this, right? Because we had to take 2 hours of RT, nursing, pharmacy, all their time to be able to do this training, and we were able to demonstrate the return on investment of doing something like that. We joined the Child Health Patient Safety Organization. I'll talk a little bit more about that. Again, we did more error prevention, safety coach, leadership methods for our medical directors and leaders on the units. And then this year, we really started to engage our colleagues in pediatric behavioral health, OB, in kind of this error prevention training. We just recently had our first reduction in our serious safety event rate, which I'll talk about. If you look at kind of the hand hygiene results month to month, just take a notice that the children's hospital units were consistently above the goal compared to the rest of the adult units. And so, but I think that's not been by accident. It's been through a lot of focused work. And then obviously, this past year we did a survey trying to understand what our culture of the children's hospital looked like, and I'll go over that. And so that's just in the last 10 years. So it makes you wonder, like 10 years from now, in the next couple of years, what care will look like. Maybe if we're lucky, there'll be another name change, but we'll see. Okay, so the 3 themes I talked about: the power of networks, surveillance of for sources of error and harm, and our culture of safety. And this is a difficult one to put our finger on, but I think we're starting to get closer. So the power of networks. So this has been a significant organizing structure for us to think about how we think about quality and safety. I'm going to talk about our involvement with the Children's Hospital Solutions for Patient Safety, which is now over 130 children's hospitals. I'm going to talk about what we've done regionally in terms of the Minnesota hospitals that take care of children, and some work we've done around that. And I'm going to talk about more broadly some quality improvement and safety networks that many of you are involved in that I'm going to highlight briefly. So the Solutions for Patient Safety. This really started among the group of 6 children's hospitals in Ohio back in the mid-2000s that got together and said, let's start getting together and talking about patient safety. They got their business roundtable in Ohio to kind of support this because they wanted to figure out ways that they could improve safety, reduce cost of care, et cetera. This gradually now has spread to really over 130 children's hospitals. And here you see the levels of support they have. So the Children's Hospital Association is their main sponsor. They got a lot of funding from Cardinal Health, the foundation, because they see this, the safety work is really critical. And then obviously CMS is one of their really important partnerships. CMS has partnered with a number of health engagement networks to look at safety more broadly. And I would say that the Children's Hospital Solutions for Patient Safety has been the one of the health engagement networks that has shown the most in terms of results, in terms of the investment by CMS. And so CMS is very interested in partnering with SPS, and therefore our involvement with them has been really important. CMS is looking for ways, this is a mostly adult-focused organization with Medicare, but they realize that there are pediatric-specific, through their engagement with SPS, there are pediatric-specific measures they have to pay more attention to, and so more to come with that. So here is basically a map of all the children's hospitals that are involved in SPS. It's basically every children's hospital you can think of in the United States, and now they've got a number in Canada, and they continue to grow. These are all the children's hospitals that are involved. As you can see, Children's of Minnesota, Mayo, Gillette, and ourselves in Minnesota are engaged in this network. We each joined it various times over the last 5 years, but now we're all, so we have that's a kind of a common platform for all of us to talk about safety. Because of how large it is, they decided to divide us up into regions, and you can see Minnesota has its own region. We're the Minnesota region because we were one of the earliest groups to actually get together and talk among the 4 of us about how we could do this better together. And so they recognized that early on. They said, Minnesota, you're going to have your own region. Because see, some of these regions are pretty big. Texas has its own, New York has its own, Minnesota has its own. And so these are their just general broad goals, and they've achieved many of these. So they want to, you can see their ambitious goals. A lot of these are ones they've had ever since the beginning. Some of these are new. This 25% reduction in DART, which we'll go into more detail about. And then these are some of the reductions that they're looking for. This is more CMS based. So 20% reduction in all-cause patient harm, and then a 12% reduction in 30-day readmission. This has been probably the toughest one to achieve because it's pretty debatable, at least in pediatric circles, whether this actually adds value, whether this is a quality metric per se. But and these are the results. So since 2011, they've seen a 34% reduction in serious harm events. So pretty significant. These are the 7 what they call HACs, hospital-acquired conditions, that they are focused on. Adverse drug events, catheter-associated urinary tract infection, collapses, falls, pressure injuries, surgical site infections, ventilator-associated pneumonia, which is now called VAE, which I'll talk about also a little bit. So here you can see the number of children spared harm over those years. So pretty significant results. If you look at each of the specific HACs, these are their percent reductions in each of these. So again, with focused work, and yes, well, how did they do this? What they basically did is said, can we get together and just agree to a very basic bundle of how to reduce this harm? And these bundles are generally pretty basic. And if you just prove to yourself that you can get to 90% reliability with compliance with that bundle, you will see reductions in harm. And that's in fact what they've seen. This is each of the kind of run charts, which each of these HACs, and you can see reductions in each of these. Readmissions have been a little flatter. The CLABSI story is interesting. The PIVI is a newer one. That's called peripheral IV infiltrates. That's a kind of a more newly recognized harm that people are starting to measure. And this is VTE is venous thromboembolism. And so again, this is something that we haven't really focused that much on in children, but increasingly people are realizing like the VTE is a problem with all our CVC lines. and risk factors we have, is it something that is preventable? And that's what the work currently going on now. Marie Steiner and Arif Somani will actually be some of the representatives from this children's hospital to help do this work. This is the CLABSI story. So, initially they had a significant centerline reduction in their CLABSI rates. Right here is when the NHSN changed their definition of what a CLABSI was, and they saw this significant spike. And so they got kind of the network together to understand this better, and more recently they've had, again, another reduction. And this reflects kind of our story here at the Children's Hospital. So what SPS did was they looked at the number of harms prevented. This is kind of the end from 2012 to 2017. And they looked at each condition, and from the literature looked at the estimated cost of each one of these conditions. And they just basically added it up. And if you add up all the reductions in harm and the cost of each of those harms, this is what the total looks like. So 9,000 children spared harm, nearly $150 million saved. So this becomes an important thing as we think about the return on investment, right? Because focus on each one of these things does require our attention and some investment of people and time and doing data entry. But what they're trying to do over and over again is that, you will actually save the system or save the organization money. And we all kind of know this intuitively. Now they're actually beginning to prove it. This is kind of the latest HAC or hospital-acquired condition, ventilator-associated pneumonia, now called ventilator-associated events. You'll notice this gentleman, Dr. Gupta, is kind of the national lead looking at this work. So I think we can all be proud of Sam and his leadership, really leading a nationwide effort trying to understand ventilator-associated events and ways we can reduce that. This is their kind of key driver diagram. They're starting to understand what this bundle will look like. So these are some SPS learning events that are happening in the next year. We've sponsored faculty as well as a resident to go to some of these learning events. For any faculty or residents, if you're interested in this work, please let us know. We'll figure out a way to fund you to get there. The conference itself is it's a part of our membership. It's just a matter of getting you there and paying for your stay. But again, we would love to have more faculty or resident engagement with this work. It's been a really positive thing for us to have more people involved in this work. We did send a MHealth board member to one of these board training sessions with Deb Bodie, our head of our quality group, and they went out to San Diego this fall, and she came away just really significantly impacted and will now certainly be a strong advocate for this work in the Children's Hospital at MHealth more broadly. So we're looking to send more board members for training at a governance level around the importance of safety and quality. So in terms of what's going on locally, this has been one of the funner pieces of this. Is back in 2013, Rob Payne, who's a former neonatologist, head of their safety, quality and safety, just picked up the phone and called us and said, "Hey, do you want to get together and talk about patient safety?" And so we got together. We invited Gillette, Mayo, our home care agencies, Hennepin County, Essentia. Now a lot of organizations come. We get together basically for dinner every 6 to 8 weeks. We're getting together next week at Children's, and we just started talking about what we're doing around patient safety. And we've invited more and more people. We've invited kind of the state at the statewide level. The Minnesota Hospital Association has been very interested and really sees us as kind of their forum to implement pediatric initiatives. And so the accomplishments of this group have been pretty significant. We've had 3 regional meetings where over 100 people have attended each time from across the state. So talking about what we're doing as hospitals. We just had our most recent meeting about 2 weeks ago. And again, it was sold out. 150 people came to that. We had some great speakers. And we had a lot of our frontline nurses and respiratory therapists go to that, and they came away very impressed, and it's helpful for them to network with other people in the state around a lot of this work. Our pharmacy groups have gotten together and have begun the work of standardizing over 75 medicines that we compound. So there was a realization at some work out of Michigan that we might send a patient home with a compounded concentration of metoprolol, or name the medication. It might be 50 milligrams per 5 cc's. Children's may send it home with 100 milligrams per 5 cc's, and Mayo may send it home with 200 per 5 cc's. And there's no reason for it. And so our pharmacies got together and said, it's an easy, we can just standardize. And they've gone through, I think now it's actually up to 90 medications they've agreed to standardize in terms of compounding. Now they're reaching out, the pharmacy board is reaching out to the big pharmacies like CVS and others to begin that work, so that when our patients go home and then they go to Children's or to Mayo, they know they get a different prescription. They know they're getting the same compounded medication. Our home care agency's done amazing work at beginning to, again, talk to each other and standardize the way they manage central lines. And even, they're starting to do work on how they manage surgical sites. So it's, again, standard across our home care agencies. And again, we've been a significant outlet or forum for the Minnesota Hospital Association. And probably most importantly, any of us, I think, would be very, very comfortable picking up the phone and calling anyone at any of these centers saying, hey, we're running into a problem with this. What are you guys doing around that? And that's happened over and over again. So the relationships that we formed around patient safety have been pretty significant. So as we think about safety networks, there's this thing called a patient safety organization. A patient safety organization is an organization that is basically delegated by the government for separate organizations to get together and talk about safety events in a peer-protected way. So you're safe in talking about significant events so you can learn from each other. The Child Health Patient Safety Organization is over, I think, 70 children's hospitals now. We joined that in 2013, and we participate in what they call safe tables. So this is a conversation that happens about every couple of weeks. We get together in a small room, and there's a webinar where a children's hospital is presenting a major event that happened in their hospital so that everyone on the phone can learn from it. We've presented at that. Many other children's hospitals have presented at it. And we've actually learned quite a bit, like, wow, if it could happen there, it could certainly happen here. So it's kind of opened our eyes a little bit about where our risks are. And again, the partnership has demonstrated a reduction in preventable harm at all the children's hospitals that are participating in this. And again, I want to thank Deb Bodie, who's really been the significant leader for us in keeping us engaged with this work and spreading this message. So these are the other kind of quality and safety networks that are out there that many of you are probably involved in. Obviously, the CF Foundation has a long history of looking at, basically it is quality improvement. They looked at various centers, who's doing it really well, why don't we do it more like that kind of thing. The Improved Care Now Network, which is a GI network for inflammatory bowel disease. SCOPE is a pediatric peritoneal dialysis, looking at to reduce peritoneal dialysis infection rates. There's the IPSO, or Improving Pediatric Sepsis Outcomes. Our ED has been involved in the ED part of that for several years. PR COIN, Pediatric Rheumatology Care and Outcomes Innovation Network, just joined that in the last year or so. There's a cardiology one. Obviously, the NICU in Vermont, Oxford does a tremendous amount of work looking at ways to just do this work better and better. So all of this does improve care because it gets other centers to talk to each other. You're entering data into usually a shared database, and so you can look at how you compare and talk to other organizations that are doing better than you are. And again, it makes a lot of sense, but there are significant barriers, right? There's usually a cost to joining these networks. You have to have a submission process to enter all this data, usually on a monthly basis. Usually requires a dedicated FTE or faculty member who's passionate about this, and then determining what your return on investment is on that. And this is we get lots of requests to join various networks. And what I would say, the thing that seems to help the most is this thing, that slide I showed before. And I think we're getting better and better at this. If we can begin to show the return on investment, it becomes an easier thing to fund. I think the worry is when we join these networks, we're just submitting data, but we may not be doing anything with it. We're certainly guilty of that as well. All right, we talked about the power of networks. Let's talk about our surveillance of error and harm. So I want to step back and think about this just in simple terms. So think if you've ever run a red light or run a stop sign. the worst thing that could happen is that you probably would get into an accident and die. Maybe you would get into an accident and you wouldn't die, but you would get into an accident. Okay, that happens relatively infrequently for every time you've run through a red light or stop sign. Usually, that what we would say as a safety event, right? Doesn't happen that often. Most of the times you run through a red light or stop sign and nothing happens, right? You're like, oh man, I was lucky, I got through it, and move on. We'd call that a near miss event. Sometimes someone sees you and you get a ticket for it, right? And that would we call a precursor safety event. So getting into an accident, getting caught. So this is where something reaches the patient, but we got lucky or nothing happened. And the near miss events are all those things that happen. They're like, okay, nothing happened, didn't even get to the patient. A pharmacist or a nurse or a resident picked up this little mistake in the orders, and we got rid of that. No harm done. We focus a lot of our time in healthcare delivery on these safety events. The one out of every 1,000 events that happen, right? We as we've talked to our teams and really organizations or industries that really get safety, put a lot of their focus on these events. So what are those things where we got lucky? What are those things that happened that probably shouldn't have happened, and we should learn from that? And so think about this mental model as we kind of go through this stuff. So surveillance of error and harm. So here are, and I just listed these out, these are a number of the things that we've done over the really last 5 to 10 years that I think have improved our ability to recognize harm earlier and earlier, and to mitigate events kind of when they happen. So I'm going to talk about I'm not going to talk about all these, you'll be happy to know, but I'm going to talk about many of them. So our daily safety call, our hack work, our harm index, serious safety event determination, our safety huddles, and then what I think is kind of the next phase of this work. And I just want to briefly mention, our rapid response teams, our handoff standardization. We've done a lot of work around this, which I think have significantly improved our ability to recognize harm earlier and earlier. And again, credit goes to all of our nursing managers and faculty and residents who are committed to this. So the residents go through an IPASS thing every night. Sometimes it's hard to see whether that has yielded a benefit, but we know it does because residents know how to give a handoff and how to receive it, and it kind of prioritizes kind of what to worry about. Same with and handoffs. That's just among residents, but when we think about handoffs from unit to unit, from the ED to the floor, from the OR to the ICU, a lot of that has become more standardized, which again I think is to the benefit of our patients. So let's talk about the daily safety call. Some of you may or may not know, we started this in 2013, in May of 2013. It happens every day at 8:35 a.m. It lasts about 15 minutes. And this is 30 leaders reporting in, talking about events that have happened in the last 24 hours, events that they're concerned about, and they're also reporting kind of good catches. This, within a few months, spread to the rest of mHealth in 2013, and this year, the entire Fairview system is running a daily safety call in the North region and South region. Just last month, we went 7 days a week, so we used to run this Monday through Friday. The Children's Hospital is the first entity in the system to say, we're going to commit to doing this on weekends and holidays, because safety shouldn't just be a Monday through Friday thing. And again, I want to thank our nursing leadership, Deb Bodie, for kind of finally getting this across. And so Saturdays, Sundays, holidays, there is a conversation that happens every morning at 8:35, lasts 5 to 15 minutes, just talking about any safety critical issues. And so what is the result of this? Well, what we've seen, kind of year over year, is this increase in our incident reporting. So this just goes back to 15, but you'll see this trend line goes back even further. And so the increase in incident reports is kind of all things that people are reporting, right? And that's a good thing in terms of our surveillance. We know that incident reporting is just the tip of the iceberg. The opportunity here is when you look at the breakdown of who's actually submitting these I-cares, it's not physicians, except for the residents. The residents have done a better and better job over the last couple of years of submitting incident reports. But I think we all have to get better at thinking about incident reporting in terms of opportunities to identify defects in our systems of care, because then it actually goes somewhere where people will respond to it. We also have to do a better job of closing the loop. So when I submit an incident report of a significant concern I have, who is then following up with me to say, you know, Abe, we did take care of that, and here's what happened. We have to get better at closing kind of that loop so that when people submit an incident report, they know something's being done with it, which I think is probably the primary complaint that a lot of people have about incident reporting. But again, incident reports are the tip of the iceberg. We know there's all this stuff that's happening that doesn't get reported, right? The 1,000 things, the running through the red light where nothing happened. So let's spend a few minutes talking about our hospital-acquired conditions. Like this is like the foundation of care delivery in terms of how we think about harm. So again, CLABSI, I'm going to focus on CLABSI, surgical site infections, catheter-associated UTIs, and hospital-acquired C. diff. So this is our overall CLABSI rate since 2013. This is kind of our goal. As you can see, our hospital's done really well with CLABSI. What you don't see is what our CLABSI rate was in 2005, 6, and 7. It was around, this is the rate per 1,000 central line days. We were around 8 to 10 back in 2005 to 2007, thanks to the work of really our ICU, Sandy Hagstrom, Sam Gupta, and the ICU group. They really standardized the way that central lines were inserted, and then the work recently has been how central lines are maintained. And so our work now has been how do we reach reliability. This little blip here is explainable. So here you look at our pediatric ICU and NICU. Again, really nice low rates. They've done a remarkable job at reducing central line infections. This is where we had issues, and this is all almost attributable to Unit 4, bone marrow transplant. We just have obviously a very high-risk population, immunocompromised. With a population of patients, particularly the epidermolysis bullosa patients, they're just extremely high risk for developing bacteremia, which may or may not be related to central lines. The CDC actually has recognized that thanks to the advocacy of bone marrow transplant, Dr. Tolar and others who wrote to the CDC and said, you know, these patients get bacteremia for things that are unlikely from their central line. They should be really classified as a kind of almost like a burn patient. And the CDC has listened to that and are going to be reclassifying EB patients a little differently starting in 2018. This is our catheter-associated UTI. I hate to even say this, but on November 15th, we'll go a year without a catheter-associated UTI in the Children's Hospital. That's a remarkable event. Again, this does not happen by accident. The main reason we've seen such low rates is because we are just not keeping lines in as long as we used to. We take them out as fast as we can. Again, thanks to the ORs and the ICUs where a lot of this happens, they've just been very intentional about this. So November 15th, we'll have a kind of a little mini dance around the fact we went a year without a catheter-associated UTI. This is our C. diff infection rate. Again, we've seen kind of a nice, slow and steady reduction. I'm really hopeful, thanks to pediatric infectious disease, and our pharmacy team, we're going to be introducing an antimicrobial stewardship program, which we've needed for a long time, which many of us have been advocating for. I think that's going to help us get this rate even lower. As you can see, again, our main problem is it's mostly bone marrow transplant. That's where the majority of our C. diff infections happen. Again, unique population, very immunocompromised, lots of antibiotics flowing through there. Hopefully with some antimicrobial stewardship, we can make some headway with this. And again, all these rate reductions have not happened by accident. The thing we've been focused on over the last year or two has been, what is our compliance with the bundle? And so here you see our compliance with the central line associated bloodstream line maintenance bundle. And the last several of this year, we've actually been much higher than 90%, which is what we wanted. So we're doing audits on all of our units around how we maintain central lines. And with that, you've seen this nice reduction in central line associated bloodstream infections. This is kind of the SPS, the Solutions for Patient Safety mantra, right? If you do this, this will happen. And that's kind of what we've seen. This is our surgical site infection rate. I want to give really credit to our pediatric surgery colleagues who've really been engaged in this work. So Dan Saltzman has led a pediatric surgical site infection committee working with our clinics and our units, our ORs, looking at ways to standardize how we decolonize kids before they go to the OR, how we manage them in the OR, and then postoperatively. Some of this is not preventable, right? If you have a ruptured appendix, it has surgery, comes back with some abscesses. That is a high rate of having a surgical site infection. And a lot of people would argue that's not preventable, which is true. So there's a baseline rate that is is acceptable, but we know we have work to do in terms of how we decolonize kids before they go into the OR. All right, let's talk about our harm index. Again, more focused on kind of the top of the pyramid. We developed just a way to look at, on a monthly basis, how much harm was happening in the Children's Hospital on a monthly basis. We shared this with our frontline staff and with our medical directors, our unit leaders. And this is what this looks like. So here you'll see what we have identified as harm. So all the hospital-acquired conditions, our adverse drug events, codes outside of the ICU, falls, other serious safety events. And so we started measuring this. In 2015, our rate per 1,000 patient days was around 1.82. We were having an average around 5 harms per month. In 2016, it was around 7.5. And so, why the big jump? And it really all came down to this CLABSI number, which was happening. Most of our 31 CLABSIs, 19 of them happened on Unit 4 on bone marrow transplant. A big chunk of that was with the EB patients. So we very quickly could look at where the harm was happening and why it was happening and give our frontline a sense of where harm happens in the Children's Hospital. This is our rate for 2017. Again, we've come back down. We've had a nice reduction in our CLABSI. And again, you look at, on a monthly basis, an email, Sam just sent an email last week. We had 10 harms last month, much higher rate than usual. Why did that happen? Well, it's all right here with this new VAE measure. And so I think Sam rightly said, at a national level, people are wondering, we don't know if this is necessarily preventable. And so it's just something that we're tracking just to get a sense of, where are there opportunities for us to put more focus on? And so this has been, I think, just a different way of looking at harm in the Children's Hospital. And again, here's that CAUTI number. It's nice to see green across the whole row. This is just a run chart of our harm since back to 2013 when we first started measuring it. You see we did have a centerline reduction. We went up in 2016, again, mostly attributable to CLABSI. We started to come down, and then this little spike here is mostly related to our surgical site infection rate and VAE. So people ask, well, that's great, that's the harm, but what among this is truly preventable? And this is what we've gotten better at. So again, looking at these events as a way to kind of begin to focus on these events. So we set up a Serious Safety Event Committee, an SSE committee, in 2015. There's a multidisciplinary group of pharmacy and our nursing directors, risk, our pediatric neurosurgeon, our pediatric surgery, a number of people. A couple of our medical directors come to this. Most units are represented, and we just talk about harm that's happening in the Children's Hospital in the last month. We include our behavioral units, as well as OB, and we go through the systematic assessment, and we ask a couple of questions. One, with this harm, was there deviation from what we consider generally accepted practice? So we look at, do we have a policy around this? What is standard practice? Did we deviate from that? And if we did it cause moderate to severe harm to the patient? If it did, we call that a serious safety event. And so, by definition, that should go through a root cause analysis to understand why it happened. This process, again, in terms of being a ripple, is now happening across all of mHealth. I think that the mHealth leadership recognized that this process was really valuable to us, and seeing kind of the events that were emerging as a result of that. And these are just a summary of the events that have happened in the past year. So again, all these events we looked at and said, bad on us, we should have done better in terms of following our own policy or standard policy that could have prevented these events from happening. And what you'll see is, obviously it's numbered 1 through 5, 1 being the worst harm, which is death. We've not had any of those, fortunately. We've had mostly 4s and 5s. And I would say that these are very difficult conversations, or frankly courageous conversations for our units to kind of admit when we've deviated from a practice, and to know that we could have prevented that. But I give a lot of credit to our leaders who are willing to have this conversation. And this is what we call our serious safety event rate. So this is a 12-month rolling average. We only get to 0 when we've had 0 serious safety events in a year. And so when we started this process in 2015, what we did was we looked back trying to figure out, what are all the reportable events we had? Let's look at all those and see if they were serious safety events. We did that. And going forward, we started to look at this very differently. You can see, as we started to peel the onion, we started to recognize there was more harm happening than any of us realized. And this is the exact same chart that every other children's hospital that's gone through this process, CHOP, Boston, Cincinnati, Rainbow. I mean, I've seen a number of these SSC charts. All their charts look like this. When they go through this process, they see an increase in their rate as they recognize what harm's happening. And then they start to see the several-year decline in their serious safety event rate. And I'm hopeful that we're beginning to see this. It's too early to tell, but over the last couple of months, we've started to finally see a reduction in our serious safety event rate. And so as we think about this, our rate is currently 0.994. We've had 9 serious safety events in the last 12 months. Our last one occurred in July. So that means on average, about every 41 days, we're having a preventable harm that caused moderate or severe harm to a child in the hospital. And so it just, again, refocuses how we talk about this stuff, and I think it adds a sense of urgency that, we have got to get after this. Our goal is to get to 0, and we're heading in that direction, but we have a long way to go. And again, this same conversation is now happening across the whole medical center, mHealth, as a result of the work done here in the Children's Hospital. Safety huddles. So this is probably something that's happened. The residents know it's happening. I don't know if the faculty know it's happening, but we have a day mid-shift huddle and a 10 p.m. Nighttime huddle. And the nighttime huddle is a multidisciplinary group that includes members from our ICU, our nighttime residents, our charge RNs, respiratory therapy. And the whole goal around this, and again, I want to give credit to Sam and the ICU for really leading this conversation at night, was to have a proactive conversation of what we call our watchers. So who are those kids, everyone knows they're worried about, so we can avoid transferring them in the middle of the night. So can we proactively do something to mitigate against the need for significant intervention, or just move them into the ICU because they need more monitoring earlier? This started in 2015. And here's a group of our residents. Are our residents who are here in this picture here? Oh, yeah, there you are. So this is an interesting example of a partnership with with the foundation. So the Hubbard Foundation gave us some money to focus on our safety work, and we took a portion of this money to deliver warm cookies every Wednesday night for the 10 p.m. safety huddle. So for the nurses and residents, again, just to mix it up a little bit and to kind of honor that conversation. And this is them thanking the Hubbard Foundation for that support and the warm cookies. So these are the results. So basically what we've seen is and again, Sam has been collecting this data, around 27% reduction of nighttime transfers to the ICU. That's a significant reduction in what we'd call unplanned transfers to the ICU, probably at the worst time of day, right, when we're least staffed. And you can see reductions in kind of the number of interventions, the total number requiring fluid resuscitation, inotropic vasopressor support, and respiratory support. So that nighttime conversation seems to be associated with a significant reduction in these nighttime transfers. And again, more work to come. So for you residents, that conversation you're having at 10 p.m. is making a big difference. So thank you for doing it. Keep showing up. We'll bring the cookies. All right. Our next steps. I'm going to talk about something that was somewhat foreign to me, I'm ashamed to say, and I suspect foreign to many of us, and that is employee harm. This is an acronym that I hope will become as familiar to us as CLABSI, CAUDI, SSI, PI, et cetera, and that is DART. And this is days away, restricted, or transferred. And the data behind this is significant. So the Solutions for Patient Safety looked at, got a number of children's hospitals, it's about 50 or so, including us, to submit their DART data to look at how much harm was happening across the children's hospital. And they extrapolate that if every children's hospital submitted their DART data, it's actually more than the number of CLABSIs that are happening. So this is, again, another level of harm. It's about 42% of all the harm that's happening across all the 100+ children's hospitals. They started to develop basically a run chart looking at the DART data. And again, here, as of the last data entry, about 43 hospitals are submitting this data. And thanks to Heather Bjornberg, who is kind of a dog on a bone about this, we got our employee health services to start helping us submit this data for the children's hospital. And this is the background or the context. So this is private industry, this is construction, this is manufacturing, and this is hospital. And this is injury and illness rates by industry. hospitals did not used to be a very dangerous place to work. We have surpassed all these other industries, but more importantly, these other industries have figured out ways to reduce harm to their employees. Hospitals have not. And so basically, hospitals end up being one of the most hazardous places to work. I don't think many of us recognize that. And there are a couple of understandable reasons for that, right? We do a lot of transfers of patients. We often, just the ethos of working in healthcare, we often put the safety of the patient before our own safety. We have a lot of needles and sharp things we're working with. There's a lot of infectious, contagious patients we're working with. And so it's a unique industry because of all that. But again, we can do better than what we're doing here. We owe it really to all of us and our employees who we work with. And so if you look at this subset of DART, these are patients that actually can't come to work. Again, compared to the other industries, working in a hospital is a much more dangerous place to work, which is really, really unfortunate. I mean, we have to be better at this. And I think other industries look at this and say, like, what are you guys doing? You guys need to focus on that, because there are significant upside to reducing the harm to your employees, right? Our employee safety is really critical to our patient safety. If we're not taking care of our employees, how can we make sure we're taking care of our patients? And so there are many costs besides just the direct costs of work comp and all that stuff. There are lots of hidden costs in terms of productivity and their morale and just retention, right? Who wants to work in an industry where they're just getting hurt or beat up? And so this is just really unacceptable, and it's just way higher than other industries. We have to get better at that. And again, I'm hoping that this will be another ripple of change here at the Children's Hospital. We can be an example for the rest of M Health and the rest of the health system. So we normally think of patient safety not equaling staff safety, like they're completely separate things. There are different people that look at it, different mnemonics, different ways you measure it. But we have to really change that patient safety does equal staff safety, and that should be a part of our overall safety plan. We can't consider them as separate. And again, this is I think many of us who work in quality and safety, I think we have all drank this Kool-Aid, and I think see this as kind of our next place in our journey with patient safety. And hopefully, I think this will be a ripple of change. If we can demonstrate our commitment to this and show reduction in DART, I think the rest of M Health will begin to recognize that and do the same. And so I think if we look at our rates, and again, it took me a while to get this data. That's part of the problems. I don't even know who those people are, but we have found some partners to work with us. These are our rates at the Children's Hospital. So again, 4.0, this is the OSHA rate. 1.99 is the DART rate. And if you look at the actual rates, this is these are by kind of department units. And when you break it down, this is, interestingly, peds vascular access. So you can imagine, needle sticks, and our behavioral float pool. And again, they get injured by their patients, which is really unfortunate. This is our delivery units, basically postpartum, and then the delivery units. You can imagine just their slips and strains that they get. And so we have more work to do with this. Again, this is the DART rate. Again, same kind of groups float up to the top: behavioral float pool and peds vascular access. And these are the incidences by the most notable ones. So again, a lot of needle stick injuries, patient handling injuries, workplace violence and assault, slips, C. diff exposure. These are the DART injuries. Again, handling, workplace violence and assault, slips and falls, C. diff exposure. So we are going to, going forward, doing a lot more work around this, trying to understand this data and what we can do as a system to help protect our staffs and employees from getting hurt. All right, next step. So in terms of surveillance, this is some interesting work that's come out. This was an article written in 2015 looking at trigger tools. So there's been a lot of work looking at trigger tools nationally, mostly in adult settings. This is the first one that was done in children's hospitals. And they really validated this was a pretty effective way to look at harm surveillance in a children's hospital. And what they said was, that the passive surveillance really relies on voluntary reporting, right? We have to submit an incident report, and that's when we know harm is happening. Well, we have to go to much more active forms of surveillance. With our electronic medical records, we should be able to do this. And in fact, what they did, and I know you can't read this, but these are the 54 triggers that they used in the study to do on kind of a systematic basis, and not to necessarily identify that a preventable harm or an adverse event happened, but to give you a pool of information to look at to begin to investigate, did a preventable event happen? And so when you look at this list, I know you can't read this now, but the list is actually stuff that we're already measuring much of this. So our pharmacy colleagues have been doing this for years, looking at high-risk medications or lab levels. Our units do this at some level. So there's hospital-acquired infection triggers. We already do that. We need to start organizing ourselves around this and then form a database so we can look at this information to start to review systematically to see, are there opportunities there? So again, more work to come. I think this will be a kind of a next step in our journey. All right, so we've talked about networks, surveillance of sources of error and harm. Let's talk a little bit about culture. Culture is a tough one, and many organizations have realized this. You can't get the safety results you want unless you address the foundational nature of what is your culture of your organization. So our approach, and again, through our work with the Solutions for Patient Safety, has kind of shown the way, said, this is a way you can do work on culture. Start doing error prevention training across all your staff and employees. And so this is what we did, and I'm going to talk about those results and our current progress. I'm going to talk about a general metric, the HRQ a survey. That's a national survey looking at kind of our culture in the Children's Hospital. It was done in 2017. And then I'm going to talk about the next steps for us, what I think is the next ripple of change, which is around diagnostic error. And again, it's whether we choose to pay attention to this. These are difficult conversations. So again, error prevention training. We've trained now over 2,600 faculty and staff since 2016. This is a 2-hour course. Many of you have participated in it. We've done work with the interns and residents around this. We've done work around leadership methods with 79, I'm sure it's over 80 leaders now. Heather Bjornberg has done a lot of work of doing training with safety coaches on all our units. And now this training has led to a commitment by mHealth to do this across all of mHealth. And they're going to do this big time in 2018. It's going to be required. The medical executive committee just recommended this become required for all medical staff at mHealth. So for those of you that are already done it, that should count. But if you haven't, get signed up. And it's going to be part of the UMP risk management incentive for departments in 2018. So again, something that we initiated in 2015 really on hardly any budget. The only budget we got was approval to get 2 hours of time for our staff in the hospital. Has now led to this significant sea change across mHealth, and I think what will be the rest of the. So this is the new brand. So they got marketing and communication involved, and we didn't have any of this. But this is going to be the brand of this error prevention training, and this is what basically these are the reliability behaviors and error prevention tools that will be a part of this training. And again, this is all based in safety science from other industries, from healthcare, where other places that have implemented this reliably have seen reductions in their serious safety event rate. It's been shown over and over again. And I know a lot of people, when you go through the training, like, whatever, but it actually makes a difference. And so our work now is how do we sustain this and do it reliably? So we did this in 2016. So what's a measure of, what was the impact of all that? So the whole entire Fairview system and mHealth did this teamwork and safety climate survey. It's an HRQ survey. It was the first kind of system-wide survey since 2011, and it was conducted last January, and it covered all these facilities. As you can see, this is this is from a database of almost 500,000 responses nationally. And so when we think about the benchmarking, it's not an insignificant benchmark. So again, 50th percentile, 90th percentile is the green line. And these are the results. So this is the Children's Hospital. Overall, we were at the 75th percentile, and this is compared to the mHealth on the West Bank, the East Bank. This is the CSE, but there's only 6 responses. The clinics, again. But significant differences at the Children's Hospital compared to the rest of mHealth, and really the rest of the Fairview system. I don't have the rest of the Fairview system, but they're basically similar to this. So like, everyone started looking like, what is the Children's Hospital doing? Why is there such a difference? And if you look at the Children's Hospital specifically, these are the various domains of the survey, and we score at or above the 50th percentile in almost every domain. And again, this isn't by accident, right? If you would have looked at the survey when we last did this in 2011, these results were not nearly this good. And so if you look at specific domains, again, overall perceptions of safety, here's the Children's Hospital, here's the rest of mHealth. Here is the overall perceptions of safety. This is by unit. And, again, we do great in a lot of our units, but in our highest risk units, namely our NICU, our PICU, and our CVICU, we have opportunities. We are below the 50th percentile, at least on that survey. And so we're about to do some focused work with our NICU and with our ICU around, why this is. And so more work to come there. And again, this is one of the more gratifying things. So this is the teamwork domain. And look at the teamwork domain across all our units at or above the 90th percentile from this large database. Pretty significant results. So again, a credit to our nurse managers, our medical directors, and our faculty who really nurture this notion that we work as a team. So that's where we've been, where we are. Our next steps are really to reinforce this work. So now that we've done this 2 hours of training, that's just the beginning, right? How do we continue to use that language, reinforce those behaviors, those best practice tools, so it just becomes a part of our daily work? That's not insignificant. It takes a lot of work, a lot of leadership of our medical directors and nursing directors or nurse managers to show the way. We're beginning to do work to onboard any new faculty or staff that come to the Children's Hospital, so they know what this means and what it looks like. And I want to spend a few minutes talking about diagnostic error, which is, again, I think the next big ripple for us in terms of how we think about this. So diagnostic error. The Institute of Medicine, now called the National Academies of Sciences, Engineering, and Medicine, released this big report in 2015 talking about improving diagnosis in healthcare. And what they recognize is that diagnostic error is a significant source of really error in healthcare delivery. And so they talked about made these recommendations to focus on these specific domains, 7 domains. We're doing a lot of work in education with Andrew Olson. He's really a national leader in this work. But we have a lot of work to do with this, and I want to meet with Andrew and with you all about how we think about this differently. And so, just the definition, it's really the failure to establish an accurate and timely explanation of a patient's healthcare problem and communicate that to the patient. And so, again, here's the data: 5% of adults who seek outpatient care experience a diagnostic care. The post-mortem exams, about 10% of patient deaths are related to a diagnostic error. And medical record reviews, that 6 to 17% of adverse events in hospitals. So this is way more than all the other stuff we've been focusing on. And I think about this, so as we've shifted to kind of pathways and order sets, we are at risk of undermining our ability to do critical thinking. And I'm looking at Dr. Schleiss because we've had email conversations about this, right? Because so you put someone on a community or acquired pneumonia pathway, but when do you know when to jump off the pathway? When does this patient look different, or how are they not responding? And that's what we have to get to. When have we made the wrong diagnosis? How do we learn from that, most importantly? And so, again, from the report, and I would encourage you to read the report, they really concluded that most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. That's really an indictment of how we, of healthcare delivery in the United States. We need to get better at this. And so this is kind of a mental model of what this looks like, from the patient's eyes, how they enter into the healthcare delivery system, how we gather information, how we communicate that information, our treatment plan, and then the outcome. And what we need are just better feedback loops of how we did it. Did we do it right? Can we do it better? And that's what we're working on. So in talking to Andrew Olson, these are kind of some thoughts he shared with me, that we need to change the culture to one of really humility and a team-based diagnosis. It's not a problem to call your colleague and say, Dr. Schleiss, this doesn't seem right to me. What do you think? I need another set of eyes and ears on this. Closing feedback loops around diagnosis. So what are our feedback loops? How do we know that the patient we sent home, who I think was going to do okay, actually did okay. And then again, I can see using this GAPS tool, this Global Assessment of Pediatric Patient Safety, as perhaps a trigger for how we do these kind of feedback loops, these reviews. So again, more work to come. So this is a quote from Tim Cook. So I want to be the pebble in the pond that creates the ripple of change. And I would say that we've thrown lots of pebbles in this pond that have created significant changes in mHealth and the health system. And so in summary, we have done a lot of work, really through our work with networks, how we do surveillance of harm, through our work with culture. These are just some examples of that work. I know there are many others, and I apologize to you all that have been doing this really critically important work. I didn't have enough time to tell you about it all. I wish I could. But first, thank you. It has made a difference, not only to the patients you take care of every day, but to the whole hospital, to the entire system. And again, as we think about networks, surveillance, and culture, we have to sustain that work. And these are our next pebbles in the pond. So looking at the way we systematically do active surveillance of harm, getting our serious safety event rate to 0, thinking about employee safety as part of our overall safety plan, again, having thoughtful conversations around diagnostic error. These are very sensitive conversations. You know, when someone comes up to me and said, Abe, you got that diagnosis of fever wrong, it was actually Kawasaki disease. Like, that's a gut punch, right? But I have to be open to that conversation so I can learn from it. And then how do we continue to leverage our local and national networks to really learn from others and teach others about how we can do this better? And with that, we have not much time for questions. I'd be happy to, I know you guys have to go, but I'd be happy to take some questions. And thank you to our parent advisor who's here to hear this talk. The engagement of our patients and families has been really critical in this work, and I want to thank them also for being a thought partner with this work. All right, thank you. Any quick questions before you guys have to... Joe.
You have been disconnected from the meeting.